get your 5 minutes reading time on the clock. Now you can see the shared screen okay?
Yep, I can. Thank you.
Excellent. Your time starts now. Case 1. Patient Record Summary. Name, Kathleen Carl. Age 72. Indigenous status, not Aboriginal or Torres Strait Islander. Allergies and adverse reactions, nil known. Current medications, perindopril, 2 mg Nocte. Past history of hypertension. Social history, married, lives with husband Paul, retired secretary. Family history is not significant. Smoking, non-smoker. Alcohol, non-drinker. Immunisations and preventative activities are up to date and normal. Scenario. Kathleen Carl, aged 72 years, presents with a lump that has her worried. She noticed the lump about 3 months ago. She describes the lump as being located on her left cheek, just below her eye. It started as a small, painless spot, but it's gradually increased in size. Kathleen reports that the lump occasionally bleeds and has developed a crusty surface. She denies any significant pain or other symptoms. Kathleen has fair skin and admits to having had significant sun exposure throughout her life, especially during her younger years where she worked as a gardener. Right, so your reading time is up. So, question 1. What history and examination features would help you diagnose Kathleen's lesion? Oh, sorry, Casey's lesion.
History and examination. Okay. So I'd want to start off by asking some history questions. So, I mean, more about her skin type, maybe her heritage, Irish heritage. So Fitzpatrick skin 1 and 2, any history of tanning, any immunotherapy or radiotherapy she may be on, any personal history of non-melanoma skin cancers or melanoma skin cancers, family history of non-melanoma or melanoma skin cancers, any history of blistering sunburn, any like dysplastic nevus more than 5 or multiple nevi more than 10. Yeah, so that's probably more on the history and yeah, more about the lesion itself, how long it's been there for, did it grow, is there any pain, bleeding, itch, has it gotten bigger? And then examination, I think dermoscopy, so general inspection, looking at it, looks like there's a piece of keratin horn and maybe some surrounding erythema. So dermoscopy, specifically performing a 3-point check, looking for asymmetry in sort of color and structure, blue, white, sorry, asymmetry in color and structure, blue, white structures, the pigment sort of irregularity. In this case, it's a non-pigmented lesion, so that wouldn't apply. And then ABCD criteria, so yeah, asymmetry, the border, is it irregular, any color changes, the diameter of it, and yeah, EFG criteria as well, is it elevated, is it firm and growing? So looking for things like nodular melanoma, which fulfills the EFG criteria. So that's examination, and then also examining, I guess, the lymph nodes around the neck, making sure there's a cervical lymphadenopathy, axillary lymphadenopathy, make sure there's no lumps that I can feel in case of metastasis. Yeah, I think that's what I would do.
Question 2. Outline your provisional and differential diagnoses for Kathleen.
Okay, so provisional diagnosis, I think keratocanthoma on that left side of the face in the infraorbital region. Differential diagnosis, so keratin horn is a possibility, maybe seborrheic keratosis, benign wart. These are less likely. Nodular BCC, I think unlikely, probably, or even a nodular SCC, potentially, but much less likely, I think. Hyogenic granuloma, probably unlikely, but keep in the back of your mind.
Yep.
Yeah.
Question 3. Outline how you would initially investigate the lesion.
Investigations. So ideally for these, you do want to do, for non-melanoma skin cancer, so keratoconthoma falls under that category. So it's a type of squamous cell cancer from my understanding. So ideally you do want to do a complete excision with a 4 mm margin. So ideally that is the best 4 mm margin with wide local excision. So either you could perform this, or if me as a GP, I'm not sure I would be doing it on the face. I'd probably refer to a plastic surgeon for the excision. But if there was no other option, I could go ahead with that. I don't think it's probably not ideal to punch biopsy these or shave biopsy, but if the patient was significantly concerned for cosmetic options, given it's on the face, it is something you can discuss and consider. But ideally, you want to do a 4 mm margin excisional biopsy. Sorry, excisional biopsy.
Question 4. Biopsy reveals a well-differentiated squamous cell carcinoma, but with close margins. What further management would you advise?
Well-differentiated squamous cell carcinoma. Sorry, with what was that last part?
Close margins.
Close margins. Was that the biopsy result?
Correct. Yep.
Yep. Okay. With close margins. So I would think that's not good enough in terms of management. So you need to be referring this onto a, even though it's well differentiated, because it's on the face, it's still a high risk area and the margins aren't clear. So you need to be referring this onto, I would say, a dermatologist or a plastic surgeon for a full excision. They could potentially consider something like radiotherapy maybe on the face for squamous cell cancer. But as far as I'm aware, I think this will need another re-excision until the margins are clear by either a dermatologist or plastic surgeon.
And what sort of excision would you recommend?
So it would be a wide local excision that I would recommend. I think for a well-differentiated SCC, yeah, I think it would be a wide local excision down to the, um, yeah, I'd probably say wide local excision. Yeah.
Yep. Question 5. How would management differ if the lesion was a poorly differentiated squamous cell carcinoma with perineural invasion identified on biopsy?
Or differentiated squamous cell with perineural invasion, you said.
Correct.
Um, okay, so I think this will need more treatment with either, yeah, it'll need more aggressive treatments, so systemic therapy, so either, chemotherapy or radiotherapy. So I think, yeah, it'll need more sort of multidisciplinary team input. So, potentially discussing about radiotherapy or chemotherapy. So, the dermatologist or the plastic surgeon would probably need to potentially involve a oncologist to discuss further sort of management, given it's gone down into the perineural layer. So she may need sort of radiotherapy or chemotherapy. So I would say maybe oncological input.
Question 6. Kathleen receives definitive treatment of a well differentiated squamous cell carcinoma. What ongoing care would you recommend?
Sorry, do you mind repeating the question, please?
Sure. Question 6. Kathleen receives definitive treatment of her well differentiated squamous cell carcinoma. What ongoing care would you recommend?
Yeah, okay. So I would recommend more frequent skin checks. So I believe for something like this, she might need to start off with sort of 6 to 12 monthly skin checks. So I would recommend yeah, more regular skin checks as number one. Number two, sun protection measures. So discussing things like she's a gardener, so wearing broad brimmed hat, sunscreen like SPF 50 plus. Trying to stay in the shade. Avoid sort of sunburn. Wearing sunglasses. So discussing about sort of sun protection measures. And yeah, so I think those are things that I would start with. Other treatment, yeah, so I guess looking for recurrence. So if she noticed any new signs, educating her about sort of skin cancer lesions, anything new that pops up that's elevated, firm, or growing, or large, asymmetrical. Maybe clinically photograph if necessary. Keep a track on any new lesions. Get someone to look at her scalp and back, the lesions that aren't commonly looked at. So yeah, that's another thing that can be done. And other management, yeah, preventative activities as well. Discussing about exit cervical screening. Dare say is up to date. I think that would be the main other management. Yeah.
Yep. What practice systems would you consider to ensure that an appropriate follow-up plan is delivered?
Okay, what practice systems? So I think number one, ensuring that you have a good discussion with the patient and documenting this clearly, the plan for follow-up. So making sure that you discuss about like the time frame for follow-up, the importance of following up, and make sure that's put in place. Put in like a recall reminder on the system software. So on best practice, you can put a recall or reminder, patient to follow up in 1 week, and they should get a reminder text sent through to them. So that's one thing that you can implement. Another thing is with the patient's consent, you can speak to practice staff, advise if the patient hadn't followed up to contact them verbally, and follow up, and maybe even seek consent to contact the next of kin if and make sure that all those details are uploaded in the record. So the patient's contact number, her address, her next of kin, all these are up to date. And email as well. Everything is all sort of set up to date, and we have practice staff who regularly follow up with recalls. So somebody specific is left to that follows up with the recalls. When the patient is booked in for the recall, that like a little reminder or a little there's a different kind of icon put to remind the GP that this is a recall and the recall is discussed specifically, and so that's not forgotten. And other practice systems, you could run audits as well, just making sure how get together with practice manager and record and look at the number of patients that hadn't followed up, and maybe put an audit system in place to look at how those numbers could be improved, what other system improvement measures could take place to assist with that. I already mentioned documentation. Yeah, and then talking about, the different ways that you can contact patients. So, contact them multiple times throughout the day, send out a registered letter if necessary, if you're not able to get in touch with them via phone or SMS. So just using different modalities of communication, not just this one modality of just maybe phone call, just varying it up. So yeah, the letter, text, um, yeah.
Okay, good. So those are the questions. I'm going to go back to question 5.
Yeah.
How would management differ if the lesion was poorly differentiated squamous cell carcinoma with perineural invasion? With perineural invasion identified on biopsy. What particular treatments or surgeries would be applicable?
Okay, so perineural particular treatments. So so radiotherapy, chemotherapy, I believe would be options. Um, Perineural invasion. Um, I I'm not 100% sure. I would double check, but something like Mohs surgery is used for melanoma skin cancer. I'm not sure if it's specifically used for squamous cell cancer, but that's something that can be discussed. So Mohs surgery as an option. Um, Chemotherapy, radiotherapy, what different squamous cell cancer, radiation. Um, hmm. Yeah, that I think that's the main ones that I'm aware of. Yeah.
Is there anything else that you would like to add
Can I
to
please
this
get
case? Yep.
Sure, sure. Can I please, just for the first question for the exam, I think, yeah, just checking sensation on the face as well is important. Just making sure, it hasn't invaded deep down to a nerve. So just checking the facial sensation for specifically, like the facial nerve and also the V2 distribution as well. So just checking the sensation on that. I'd just like to add that in, question 1. Um, and sorry, just for question I think, and sorry, can I please get question 6?
Question 6 was Kathleen receives definitive treatment of a well differentiated squamous cell carcinoma. What ongoing care would you recommend?
Yep. So I spoke about the regular skin check. So ideally, like even 12 monthly initially, post, talking about, yeah, educating about the skin check. Um, any other treatment? What treatment? Yeah, I talked about sun protection measures. I guess, I mean, I don't know the significant relevance, but even just letting the family know as well. I mean, it does, family history. It is important for family members to be aware when, someone in their family is diagnosed with skin cancer. So, I guess, yeah. So, sorry, as part of that, I guess assessing her mental health as well. So, just making sure how she's after, she's undergone such extensive treatment for skin cancer, how is she coping mentally as well? So, just looking at her mental well-being, making sure that, assessing her mood, checking for depression, performing a risk assessment if appropriate, discussing her mental health. So that's an important aspect. Um, and yeah, I think that's it for that one. Yeah, but that's probably it. Yeah.
Is there anything else you would like to add for the case?
Sorry, do you mind just repeating question 4, please?
Question 4. Biopsy reveals a well differentiated squamous cell carcinoma with close margins. What further management would you advise?
Yeah, close margins. So it's not clear margins. So yeah, I think I would stick by my original answer, which was to refer on because yeah, I don't think close margins would be good enough. I think that would probably still need, given it's a high risk area on the face, I think I would still refer on. So yeah, no, I would stick with my original answer for that one. Yeah, that's it. Yeah, thank you.
No worries. We have 5, 4, 3, 2, 1, and that is case time. Very well done. So, skin cancers. First of all, I want to say very well done. Again, I can see this is obviously something that you have had a fair bit of practice at. This is something that you seemed pretty comfortable with. And from a kind of pass-fail perspective, a clear pass. You knew what you were talking about. You knew the preventative actions. You knew how to identify skin lesions. Margins for a lesion like this, it's always depending on which source you go to as to what they'll say the margins are. As long as you're saying something sensible, and 4 millimeters, fantastic. Kind of 3 to 5, you're usually pretty safe. And if you do have a suspicion of malignancy, it's always that more is more. More is good. I think your margin choice was very appropriate. How do you feel you went?
I didn't feel great. I didn't think I did that well. I was I mean, I didn't get the diagnosis either. I said keratoacanthoma, so I wasn't sure. I mean, even question 4 and 5, and even 6, I just didn't. I'm not sure if I answered it correctly. Probably not as. I didn't think it was probably one of my good cases, but I don't know.
Yeah. So the tricky thing is, and this one is intentionally left vague, the time frames are left to kind of muck around a little bit. And yes, one of the key differentials here would be keratoacanthoma, is that small lump that rapidly grows. Yeah. And this is obviously not a tiny lump. This is obviously quite noticeable. And so you very much would consider keratoacanthoma as a key differential here. Ultimately, and this is something I try and reassure people, even if you're not exactly sure what it is, if you've got enough alarm bells to say it's not normal and I need to cut it off and you're taking sensible margins, I think you're usually playing it pretty safe. Ideally, yes, you know exactly what it is, but ultimately none of us know exactly what it is. That's why we send it off for histology. So don't beat yourself too much there. This is one of those kind of high risk areas for SCCs. And so this would be SEC in the exam as well. But I think he still gave some very sensible differentials there. And again, as long as you're on that, it's probably nothing, don't worry about it. I think you're going to be fine.
Yeah.
Now, you weren't quite as structured in some of your answers, a little bit kind of, you would come back to answers as you remembered them later on, and that's fine. And that's what we do in real life as well. The important thing is that you don't just drop that and say, okay, well, I didn't say it in the flow, I'll do that next time kind of thing. The point of these exams is that we appreciate you're under a lot of stress. So there's going to be a bit of jumping back and forth. And when you've got that time at the end, as you did, can you read this question again, or can I add to this question? Perfect. The time is yours. It's there for you to use. And so if you want to go back and add things to other cases, go for it. I was trying to get it out there, and you pulled out Mo's surgery. Fantastic. That was the answer we were looking for as well.
Oh, right. Okay.
Especially,
I thought that was only for melanoma.
No. So any higher risk or invasive malignancy, it's all about trying to spare as much tissue as possible while getting definitive management in place. So
Sure. Okay.
It is not a well tolerated surgery. It is incredibly long, incredibly tedious, incredibly uncomfortable for the patients. But if you're trying to save as much tissue as possible, it's still considered to be the gold standard. So
Sure.
In one of these as well, as long as it's not a dangerous answer, as long as it's not a zeroing answer where you're potentially going to harm the patient, kind of as you did, you can float out, look, I'm not 100% sure, but I think they would consider Mo's. I thought that was a really nice way to kind of, put it out there that you're aware of this procedure. You weren't entirely sure if it was applicable in this case, and ultimately, let's be honest, the surgeon's going to be the one making that decision anyway. But that's a nice way to just flag, hey, I know this exists and it's applicable to these kinds of areas. So that was pretty good. Keep up the study. You're obviously doing heaps of study. It's definitely paying off. Time management is not so much an issue, so don't be afraid to take a deep breath from time to time and just kind of let yourself collect your thoughts to get that little bit more kind of structure in place. But otherwise, keep on doing what you're doing. It's working well.
Thank you, Kane. Yeah, so do you mind if I just quickly ask you, so my answers for question 5 and 6, were they on like track, or was I completely off about those?
Right on track.
Right, okay.
So the point was you could appreciate from that histology that this was that next step up, and that they were going to need to move on to all those adjuvant therapies as well.
Okay, okay,
So
all right.
you hit the nail right on the head there.
Yeah, okay.
And question 6 about what ongoing care do you recommend? Yeah, it does fall back to those 6 to 12 monthly checks, checking regional and local lymph nodes, and all those other kind of preventative measures as well to prevent further recurrence or further skin cancers from developing. So absolutely perfect.
Thank you. Thank you so much, Kane. That was very useful. Thank you.
Oh, good. Another thing that I snuck in here, and they will sneak in on the day as well, is a little bit of those kind of policies and procedure things. So kind of what clinic practices are in place. Because remember, they've got only a few cases to try and examine all of the domains of the RACGP curriculum. And so little things like that are a way to sneak those in. But I think you had a very nice, very structured approach to that. Well done.
Thank you. Thank you very much, Kane.
No worries. I will leave you to it then. I'll let you log out.
Yeah. Do I just leave this?
Yeah. Yep.
Thanks.